Okay, so I put together this presentation for genital pelvic pain and penetration disorder. This is going to be an overview. So keep that in mind, that this is, as you can imagine, things that cause sexual pain can be a wide variety of different things. The other thing that has happened with the new DSM-5 is that they combined two things. They combined dyspareunia and vaginismus together for genital pelvic pain penetration disorder. So that's just important to note if you're from the past DSM that they did that. Okay. So first we're going to go through the criteria, just so you're aware of that. So the criteria for this particular disorder is persistent or recurrent difficulties with one or more of the following: vaginal penetration during intercourse, marked vulval, vaginal, or pelvic pain during vaginal intercourse or penetration attempts, marked fear or anxiety about vulvovaginal or pelvic pain in anticipation or as a result of vaginal penetration, and marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. And then criteria B. Criteria A must have persisted for a minimum duration of approximately 6 months. And criteria C, as is common with all of the mental disorders that we deal with in the DSM, criteria A causes clinically significant distress in the individual. Part D, the dysfunction is not better explained by a non-sexual mental disorder as a consequence of severe relationship distress or any other significant stressors, not attributable to the effects of substance, medication, any medical condition. Now, it does say medical condition, but keep in mind that even though it's sometimes sexual pain is caused by a certain medical condition, that's not really what they're talking about here. At least that's in my interpretation. So just keep that in mind. This is also important, whether it's lifelong or acquired. Sometimes with people who have had no pain with vaginal intercourse, all of a sudden something can happen that could create that. And other people have had it where it's constant. So if you want to think about different medical issues that can cause any kind of vaginal pain, things like endometriosis, vulvodynia, sexually transmitted infections, which can resolve. The other ones can resolve too, but if there's an infection, it hurts, and you get an antibiotic and it doesn't hurt anymore, that obviously is a result. Cancer, different types of vaginal types of cancer, and menopause, and other things I'm probably not thinking of right now, but there can be different things that will create vaginal pain. Okay, so first we're going to assess, and I included David on here. And the assessment part's really important, and I'm going to give you some ideas of different questions that I ask. By all means, these questions are not exhaustive, but I wanted to give an idea of things that you want to think about when you're assessing your clients for this. So one of the first things I ask is if they have any medical issue that's causing the pain. So I want to know if they're like, yes, I have endometriosis, or yes, I have these things. Sometimes they have seen a doctor for their pain. Sometimes they have not. I always like to ask who they have seen. Sometimes it will be, it's not as common anymore, but sometimes it might be a primary care doctor. Most of the time, if they've seen someone, it's a gynecologist. Keep in mind that gynecologists are vastly different in terms of experience and specialties, just like therapists. So they may, you may go to say, that there's sexual pain or whatever, but the gynecologist may not know what that's about. And so I like to know these things, because sometimes I find that people will need to be referred to someone who specializes in sexual pain. I also ask where you feel it: at the vaginal opening, inside the vaginal opening, deeper pain in the pelvis. You may wonder why I ask these questions. Since I'm not a medical doctor, the reason I ask is because I want to know what kind of pain they're dealing with. And I also ask what the pain feels like. Is it sharp, burning, stabbing, cutting, something else? It gives me some ideas for further in treatment, what they're dealing with. And it also helps me to understand how they understand their pain, and then how they may be talking to doctors about it. Doctors aren't great about asking about sexuality things unless they're specialists, and people aren't great about reporting some of these things. So sometimes I find that they haven't really thought about this. No one's asked them this question, and it helps them to then communicate with their doctors better. Do you feel the pain with all types of penetration, like a finger, a tampon, a speculum, a penis, a phallus? I want to know these things because sometimes people will say, I have no problem with tampons, but I have a problem with a penis, or I've used smaller phalluses, but I can't use a bigger one. These are things that are helpful for me to know in terms of understanding their pain. How long has the pain been occurring? Does it happen every time? Have you had a time when you didn't experience pain? This is the lifelong versus acquired. And does it happen every time? Tells me a little bit more about what is happening. Do you feel like your muscles will not allow penetration? How often and for how long? With a vaginismus type of case, people will often report, I feel like nothing can go in there. Like it just won't allow it. It won't happen. Basically what they're saying that is because the muscles are so tense and tight that it's not allowing for anything to move. It'll be described sometimes as like hitting a wall. I don't know if you can see this last question because of the screen share, but I also want to know if are you familiar with your body? Do you feel comfortable with your anatomy? And do you know the parts of your body? This is important. Sometimes people don't, because our sex education in this country isn't great. Sometimes people really don't know what their anatomy is and how things work. So it's important to know that because, again, you might need to do some psycho ed while you're talking about some of the treatment options. Okay, psychological. How do you feel when you anticipate penetrations? What are the symptoms that you experience? So maybe someone will tell me the physical symptoms, but like, no, I want to know what are some of the symptoms? Are you feeling intense anxiety? Are you having flashbacks? Are you having a panic attack? What's happening for you? Do you avoid penetration, or do you engage in it even if it's painful? So some people will continue to engage in intercourse or some sort of penetration, even if it's painful to please their partner. You want to know this because it will set up a negative cycle with regards to being sexual and having penetration if it's continuing to be painful. We don't want to repeat things that hurt. And now all of a sudden you start to have this disconnect, like I'm just doing this for my partner. That is not a good scenario you want people to be in. So you need to know if that's happening and really encourage them not to do that. How did you learn about sex? How comfortable are you talking about sex? I want to know these things too. Again, this gives me an idea of if there's just overall anxiety around sex in general, if there's problems talking about it, how do they talk to their partner about it? How do they think about it? These are things I want to know. Were you told any negative stories about sex? If so, what were they? Sometimes I found I've had a couple female clients come to me and say they've been told, that sex is really painful, that sex is awful, it feels like falling down a flight of stairs. Like, if you've heard some of these things, why would you want to engage in that? And why would you even want to try? Because you hear that it's really painful and awful. Have you felt feelings of sadness or depression about sex? As you can imagine, this can be a really big challenge for people and a stress on relationships, which we'll get to in the next slide. So I want to know how sad and if there's feelings of hopelessness and those sorts of things that have happened. Have you experienced any sexual trauma? If so, what has happened? Have you had any other bad experiences with penetration? This is important. It's also important to know that painful sex does not mean there's been sexual trauma, but certainly there are people who have had sexual trauma who then have painful sex. So you want to know this. As you can imagine, if there's sexual trauma, there's a lot of other questions you're going to want to be asking to understand their sexuality and what has been happening with their sexuality and what are some of the issues that need to be addressed. So again, like I said, this is a very broad thing. That we're not talking about sexual trauma and painful sex or sexuality in this particular presentation, but you do need to know this because it's a very important piece. Social. Are you in a relationship or relationships? Has that pain put stress on those relationships? If you're single, how have you navigated this issue while dating? That can be a problematic thing for some people. How has the pain impacted your ability to be sexual without penetration? Some people are able to be sexual in other ways and they're fine. Other people, especially those who really focus sex on penetration, start to shut down other ways of being sexual. And they're like, I can't do this, so I can't do anything. And now they're not really connected with being sexual anymore. So you really need to ask those questions. And some people just, if they feel a lot of pain in a vulva area, they can have pain during any kind of touching in the vulva, with the clitoris or any other parts. So you really need to know that. Have you told anyone about this issue? What are your supports? Sometimes people talk about these issues with friends. A lot of times they won't. And it becomes kind of the secrecy thing. And that's really problematic too, because anything that's secrecy, you think you're the only one, no one else experiences, and that creates its own issues. Are you trying or wanting to get pregnant at this time? I put if applicable. Obviously, if you're working with a 55-year-old woman, that's probably not a question you need to bother with. But you want to know this. Sometimes people are actively trying to get pregnant, and this is a huge stress because they're unable to have penetrative sex. And they are scared that they've got to figure this out because they want to have a baby really quickly. So it adds an extra pressure and anxiety on it. And you need to know that so that you can work with them around that. What are your fears for a relationship or getting into a relationship? A lot of times there are fears about this and what will happen. Will I be accepted? Will anyone want to be with me? All of these questions. So you want to know that stuff as well. Okay, so interventions. How can we help? Again, this is going to be an overview of how we help. It's not going to be, there's all different types of situations, which brings me to, oops, that's the wrong one. Here we go. One size does not fit all. I included that, and not because you don't know that. You all work with clients. You know that one size does not fit all in therapy. But one of the reasons I put this in is sometimes sex therapy, because of its behavioral nature, makes it feel like that. Makes it feel like, oh, we just need to do these steps 1 to 10 or whatever, and that will resolve the problem. And we want to keep in mind that we really need to tailor this for each individual. Okay, we'll talk about 2 sexual response cycle models, just to, again, keep in mind of the individuality that happens here. This is Masters and Johnson's and later Kaplan's model of sexual response. Kaplan added desire in it. Masters and Johnson did the arousal, plateau, orgasm, resolution. As you can see, this is kind of a basic model. And some people will argue that it doesn't really represent women, for example. I include it because you don't want to stereotype anybody. And for some people, this is exactly how it happens. There's some desire, there's arousal, there's a plateau, and there's orgasms. For some people, there can be multiple orgasms, and then there's a resolution period. Pretty simple, but it's something to kind of keep in mind of how the sexual response cycle can work. And then we have Roseberry-Basson's model. This has been geared towards women, but again, we don't want to stereotype. So in the middle, we have a spontaneous sexual drive, which can certainly happen for everybody, right? But the other factors in here is that sexuality and sexual desire can come from other sources. It can come from sexual stimuli that can then go to sexual arousal. It can come from emotional intimacy, emotional and physical satisfaction, just any kind of arousal and sexual desire. So you can think about, like, I'll just use an example of something that I've heard from a woman. You know, when I see my husband interact with our children, I feel very close to him, and that creates some sexual feelings for me because I feel very close to him. So that could go on like the emotional intimacy, or when we really go out on a date and I really feel heard and listened to, I feel very much closer and like I could be sexual. So it's, as you can see on the bottom, it says affects female sexual response. So it really is geared towards women. But again, I don't want to stereotype because we have all different people out in the world now that really could resonate with this model. But it's important to kind of think about, how does my client kind of access their sexual energy? How do they get interested in sex? Before the pain, since the pain has happened, you want to kind of have an idea about what that looks like. Okay, cognitive beliefs. Here's where we come in the C part of the CBT of sex therapy. You really want to identify what problematic beliefs or cognitive distortions are present. They could be a lot of different things. I just gave some examples. I'll never have penetrative sex. I'll never get over this. I can't manage my anxiety. No one will ever want to be with me. I can't be helped. Penetration will always be too painful. The last one's a big one. I'm defective. I can't be sexual because of this problem. So some of the things that I talked about can be things that or penetration that doesn't involve some type of pain might be unrealistic. It's more of managing the pain. So that's where some of these, I'll never be able to do this, I'm defective, I can't be sexual. We really want to talk about maybe there's other ways you can be sexual. You know, think about someone who has dealt with cancer and now it is too painful. There's been some atrophy in the vagina, and they're just not able to have that kind of penetration that they used to have. Then it's working on expanding and dealing with what other ways can we be sexual. But then there's other people who just can't understand how they ever could be sexual, even though it could be a treated issue, like a vaginismus, for example, that doesn't have any biological component. But these are the types of things that really can come into play and then can create problems in the relationships and with some of the other behavioral interventions. Wanted to put a little note here about medicalization and disconnection. Clients who have a history of regular medical issues or medical interventions in the vaginal area are at risk of disconnection from that area, feeling sexual or feeling sexual at all. So medical interventions can be painful. It's in a sterile environment. It's not a sexual environment. It's a very non-sexual environment. And there starts to become this disconnect with this is a problem area, or this is something that doctors need to treat something, and it no longer becomes sexual. That is definitely something that happens. And when you have this, you're going to need to work with your client on rediscovering their vaginal area as a source of pleasure, or even being sexual as a source of pleasure. Because remember, some people, if it's intercourse is a problem, then sex is a problem, because they equate those two together. And if you have someone like that, they could see it as, I'm just not sexual anymore. I have to say goodbye to my sex life. So that's totally not true. But we need to help them work through that. So really just ask about their experience. If you have somebody who has had different medical procedures or is under treatment for a biological issue in the vaginal area, or have had some kind of surgery or anything like that, ask them what their experience has been like that. I'm not saying that everybody who's done a lot of medical interventions is going to have this feeling, but it is something that can happen. So you really want to talk about that. Vaginal dilators. Okay, I put at the top here, know your client. So when we're talking about vaginal dilators and when we're talking about painful sex, there's an element of anxiety. So there's the anticipation typically. If there's been pain, anybody who's dealt with pain, you can anticipate pain, and that causes a tensing reaction or an anxiety. So you really want to know the level of anxiety of your client. You want to know, have they had penetration before? Have they never had penetration? Have they had some of these medical things that have caused some trauma? You want to know what's going on so that you can help pace them. The thing with anxiety is you have to keep challenging and pushing, but you also can't push too fast, or you lose people and you flood them. So there's this nice balance of continuing to kind of talk with them and see where they're at. Always work on the smallest size first. Even if you've had someone who's been able to have penetration in the past, it just helps to gain confidence. And they're like, oh, this one's fine. Oh, this one's fine. They'll eventually get to the one that is causing some pain. Use plenty of lube. Kegel exercises. I don't know if everybody knows what those are, but around the vaginal opening is a muscle called the PC muscle, or the pubococcygeus muscle. That is part of the pelvic floor. When vaginal penetration is anticipated and there's anxiety about it, that muscle can tighten. So you need to teach people how to manage that muscle. The best way to teach them is telling them if you need to pee, The way to tense that muscle is to stop the flow of urine. And the way to release that muscle is to start the flow of urine again. And that's how you tense and release that muscle. This is very important because if they start to tense, like in a vaginismus case where there's that involuntary tensing, you're going to want to help them learn, learn how to isolate that muscle and relax it before starting anything with the dilators. I usually tell my clients to keep it inside for 5+ minutes. That seems kind of like, ugh, I don't want to do that. That sounds awful. What am I going to do? Well, everyone can look on their phone, you can read or whatever. The reason I say that is because you want them to get used to the sensation of it inside, and you're also helping to stretch the PC muscle out, which has likely gotten very tense from the pain issues or vaginismus. The other thing I forgot to mention is some people have a very tense pelvic floor. So that just in general, like not necessarily related to pain. And then when you put pain on top of it, then they have a very tense pelvic floor. So there needs to be some of that stretching out of the vaginal opening. Also useful to note that some clients who have a really tense pelvic floor, they're really struggling. It's a great idea to get a physical therapist involved. There are physical therapists who specialize in this particular issue. That's who you want your clients to see. They will likely use dilators and other types of methods to help. They could be a great adjunct to your treatment. And when speaking about adjunct, also make sure that you have a release for the doctor that is treating them for any kind of pain issue that's medical. You definitely want to know what is going on and have communication with them. When starting a new size, always use the old size first. Again, this helps build confidence. If someone has mastered the old size, then it's easy for them to start with that before they use the new size. You may wonder, when do you move them on to the next size? Usually I'll move someone on to the next size when they're like, this is pretty simple. I don't have any pain. I can do this, or I have pain that's manageable. And sometimes you'll have clients who are eager and very motivated, and they will move up and you'll be like, oh, okay, that's fine. You just want them to feel comfortable with the size that they're using before they move to the next one. Breathing exercises if needed. Some people get really anxious, or they might have panic or that sort of thing. You want to teach them some really basic breathing exercises. Maybe they start with those before they start their dilator practice, but you definitely want them to have something so that they can regulate the anxiety, because again, you get anxious, you tense, it's going to be really challenging. Sexual versus non-sexual. This is an interesting area. So some folks will have people practice the dilators while trying to use them as for masturbation, or like feeling aroused. So maybe we'll read some erotica and then use the dilators to kind of start connecting that penetration with sexual. Or you can do non-sexual. I'll be honest with you, I tend to do more of a non-sexual and then add the sexual connection later as they get more confident with the dilator. So there is no right or wrong way to do this. It really depends on your client. High anxiety, I tend to do non-sexual, or people who are just not as connected to their sexuality. Let's get this more comfortable. Let's help you to feel like this is possible and doable and all of that. And we'll add the sexual in later. But it just really depends on your client, and it really depends on who you are as a clinician and what you feel will work the best. Be a cheerleader. This is the time when you are just like, that's fantastic. You did such a great job. You can totally do this, because this is hard. This is common with any kind of anxiety issue. You want to be a cheerleader for your clients because it's hard to confront anxiety. The thing that we all want to do with anxiety is avoid it and hope it goes away. All of us know that that's not how it works. So we want to be an extra cheerleader to like, you can do this, you're doing a great job, and be kind of coachy with this sort of thing. Exercises with a partner. Now we could probably do a whole thing on this, but this is what I have here. So once someone gets used to using a dilator that they feel is equivalent to what they might want to use during sexual interaction, I have them use the dilators with a partner, and I have them practice inserting the dilator with the partner present. Second step would be, and not necessarily like do this, then do this, then do this. It might be a couple sessions of having them insert the dilators with partner present, a few more sessions of them guiding the partner's hand when inserting the dilators, then having the partner insert the dilators without their guidance. Then the fourth thing would be working on inserting a penis or a phallus with or without their guidance. Again, there's a whole lot we could talk about with this, but that's kind of the basic thing to transfer from dilators to a penis or a phallus. Also keeping in mind, you might want to sprinkle in some sensate focus exercises with that, or do some sensate focus exercises if the client and the partner are not connecting sexually at all now. Like penetration couldn't happen, so sex has not been happening in any form. You want to see where they're connecting sexually. Do we need to do more of this and more around sexuality before we introduce the dilators in sex? So I have here start connecting dilators to sexual touch, work up to inserting penis or phallus with sexual touch. You want to be talking about learning how to communicate about sex. Some couples may have this down, others might not. You know, what feels good, what doesn't, what are turn-ons, fantasies. Again, we could have a whole presentation about all of that stuff, but you want to have them start learning how to communicate about sex if that's a problem. Widening the sexual focus from only penetration, super important with people who may never have sex that isn't painful, or they just can't tolerate penetration. Then you want to teach them how to be sexual in other ways. I put here the pie exercise or the pleasure wheel. Basically what that is there's a couple ways to do this, but it's structured like a wheel, and having the couple together decide sexual behaviors that they actually really enjoy without, and in this case, maybe without penetration. You can also do the pleasure wheel or pie in different ways with like affection, things they like for affection. I know some of us do like a 3-part type of way with that. And the one way I do it is I'll do affectionate behaviors as level 1, like level 2 is behaviors that get you interested in sex and get you really thinking like, I want to have sex, and level 3 is actual sexual behaviors. So this is just something that you want to really widen. I would widen the sexual focus from penetration if anyway, even if they are able to have penetration, because I think that's just my bias. That's more interesting and fulfilling sex rather than just relying on that. Consider involving the partner in the sessions. Some partners don't want to be, which is fine. You can work with that. But it's really useful to know who you're working with. For example, you could have a partner who's very submissive, and they don't want to push, and maybe you do this on your own and that sort of thing, which is nice and very supportive. But sometimes you need someone to say like, hey, we can do this, let's try it, and act more of a coach. Or if you have a partner who's like, you need to figure this out, this is your issue, I don't want to be involved with it, you want to know that too, because then this is a dynamic that you need to work with your client. And then that is the end of my presentation. I put thank you so much. I really appreciate it. I'm very passionate about women's sexual health and helping women achieve healthy sexuality. So I'm happy that you're all here to partake in that and to learn more about it.